to the meeting being recorded, please come on mic and share that with us.
Okay.
Thank you. All right. Do you folks do we have everyone in that we need for Region 1? If I don't hear you say something, I'm going to assume I can move on. Region 2, West Central. Lakes Region, Region 3.
Yes.
Thanks, Maggie. Region 4, Riverbend.
Yep.
Thank you. Region 5, Monadnock.
Good morning, everybody. We're good.
Thanks, Phil. Region 6, Nashua.
Yes, good morning, Diana. Thank you.
Morning, Cynthia. Region 7, Manchester.
We're good.
Thank you, Allie. Region 8, Seacoast.
Yes, we're good.
Thank you. 9, Community Partners.
Yeah, we're set.
Thank you. And 10, CLM.
All set. Thank you.
All right, great, thanks. I think from the department's perspective, I know we have several people out of the office today. I see BMHS is here. Evelyn, are there anybody else from the BMHS side that you that we're waiting for?
I don't think there's anybody that we're waiting for. So I think we're good.
Brittany, it says Brittany, people added to the chat. Do we think that she's going to join today? No, it looks like she's off. 8 minutes ago. She might just be running a little late. Okay. All right, let's go ahead and then. Thank you, everybody. So we have a couple of topics for today to come back on with some later news. Let's start with the directed payment, the CMS, our application for the state fiscal year 25 directed payment. We did get approval from CMS. It came in, I think last week it came in, and that means I need to make sure we finalize the guidance to you folks. And there were a couple of things that I know that your IT teams were working on, and one was coming to sort of a unified approach on how the CMHCs would sort of report the start of the clock. Patrick, you're on right now, right? Does that sound familiar to you?
Yes, it does. There was a summary sent out that the data and reporting group had come to consensus, and there was a communication sent out, I think, recently on that.
Was that sent to me? Do you know?
I don't know, but we can get that sent to you.
Okay. Can someone walk us through what you folks had landed on?
I'm not looking at it right now. Heather, are you on?
I am. I'm here. So if I can remember correctly, what we decided was the first contact would be in alignment with CCBHC, that it needed to be a patient or a legal representative for that person if they contact you. We agreed on being able to put that contact into our system. We also agreed that we probably wouldn't report that first contact until the person is open to us. I think that's everything. Maybe I missed something.
Yeah, I think that, yes. So when we say open to us, what Heather is referring to is the centers capture information, but they can't report basically that information without having additional information about clients. And so therefore we would not be reporting people until they became active. So there was a lag issue. The other thing is we can send that. There was a lot to it. That's why I thank you very much, Heather. Pre-coffee,
Yeah.
right?
Yeah, pre-coffee.
So I do believe that's all accurate.
Okay, so when we, thank you very much for that. When we last talked about it, the notes that I have did say aligning the initiating and conclusion activity parameters with time to serve under the CCBHC models. That would be for the new one for the gets an intake within 30 days of first contact. So we will
Oh,
be
sorry,
using.
there was one more piece, sorry,
Yeah.
that we would do a risk assessment and triage on that first contact. So that
Okay.
could be like a 1 to 2 question, just to be able to identify where
Right.
that patient is going routine or if they're going crisis, right?
There's
Right. Okay.
pre-screen. More or less.
Is that an operations issue or does that get reported in data?
It would get reported if the individual became a client again. I'm not sure if that answers your question, Chris. There was a lot to this. I mean, that's the thing. You're asking us to kind of summarize. And I think the best way to handle it is we will get you kind of the operational definition detail in written form that we have agreed to. And then I think that then presents the opportunity for us all to move forward. And what I will say, Christopher, is that we had all planned and come to consensus as a group. All the CMHCs were present and they all had taken the information back to the individual CMHCs.
I think the email I saw yesterday said that 6 were present and made that decision, and I didn't get anything until I saw that email. So that's why I asked the question about data versus operations, because we're not a CCBHC and we're not doing a screening, and I'm not necessarily interested in altering my operation, but I'm happy to produce the data.
Chris, even for the operation for CCBHC, it's really a simple triage question that your staff probably already do, right? If somebody calls and asks you for an intake, you're probably already doing some sort of assessment. One question to make sure they shouldn't be seeing your ES instead before you schedule them. It is
I understand, but is that data that's being reported? Because that's a whole different thing about reporting a set of data on an assessment versus reporting.
No,
the
we're
data.
not
the
reporting it
assessment
on
isn't.
anybody unless or until they become our client. And then it's very simply, they did not screen into ES, which if you did a phone call and they didn't go to ES, I would think you could do an automatic default data, but I'm not the data person. So that's my understanding again, right? Like, so it's not meant to be a heavy lift for non-CCBHC folks.
Right, and
Yeah.
you're already reporting first contact, Chris. It's in your episode file. It's just what your operational definition of that first contact is.
Yeah,
No, like I said, the data issues, that's a different
So-
issue than what you do at first contact.
right. Chris, I think that a better way to approach this, and I apologize for the way it's kind of unfolded here because I probably should have responded this way when Diana asked it. We will send out the written guidance that the group came to consensus about, and I'll double check, Chris, and I'll be happy to talk to you offline about the participation levels and follow up on that and answer any questions you have. But I think at this point, what we'll do is we'll send out what we agreed to. And if people are looking for me to actually give information on the participation levels of the group, maybe you and I can just check in on that, Christopher, before I forward that out. Does that make sense?
That's fine, thank you.
Yeah, and
Okay.
Chris, it's not, again, I think I want to say, it's not the reporting of that issue. It's like a single question.
Right.
That's not being reported. It's just the definition of what the first contact is. And I guess I hear that there may be questions about it. Diana, I just sent you what Heather had sent me and that I sent to the CEOs just so that they could be prepared for this morning. But we need to move this along. I'm just going to say it outright. We need to move this along. And this stuff is coming there. We just got to get this definition down, and the definition I saw seemed reasonable. And we've got to move it forward.
Thank you. So just what you do in that first contact, the fact that you call it a first contact is fine with us. We just, from the directed payment perspective, we just need what you're going to use as the start of the clock and how you're going to document it for the state, because as you folks know, we can pull up the utilization once the intake happens, so we can see when the activity has closed on it to qualify for that payment. But if we need to know how you folks are going to let us know that the clock started. And it's fine if you're not going to transmit it to the state, if you will, until after the person has the intake. But that's, I need to be able to put in the guidance what we have to expect to get for that data point.
Well, we do have a meeting at the end of today, this group that we're referring to. And so what we'll do is we'll put that together as part of that meeting, and then we'll get it out to the CEOs for a blessing, and then it'll come your way.
Okay. Okay, great. So you think that by next Friday we'll have it? That gives you folks enough time to have your internal discussions, or earlier?
We'll get the communication out to the CEOs in plenty of time for that.
Okay.
I think.
And there were, well, at least there appeared to be 6 centers who'd already agreed to what had been that the definition in the CEIO group.
Okay.
So, yeah.
And actually next Friday is a holiday for us, so I'm sorry I mentioned that, but all right, so that's good. Thank you so much for that. And I know I just sent these the 2 topical areas. This is where we have the most new information, and I want to try to be as timely as possible because we are sort of coming down to the wire on these many of these topics, so I appreciate it. Okay, so we have the start of the clock. We had already worked through the design discussions. I think the
Pattern.
to recap, we are starting the clock for the discharges on the day they discharge, I believe. Hospital DRF discharges. Not first contact, but a referral. Okay, so not first contact, but a referral. Same day, next day. There'll be an activity scene. All right, so I'm just seeing if I have any other questions in there from our last conversations. I don't think so. All right. If nobody has any other questions about the directed payment, we can move on to the crisis services. Okay. All right. I believe we shared the state plan amendment for the crisis services that we had approved from CMS. Is that correct? You folks all got it? Okay. So part of what has been going on, largely associated with the conversations for the CCBHCs, because of the payment model associated, there services, crisis services, to be billed to that special crisis services rate. And as I think all 10 CMHCs have experienced, your teams are responding in deployments, they're providing crisis stabilizations in follow-up sessions, et cetera. And your staffing resources on your mobile crisis teams can vary depending on what the person needs, who's available that day, et cetera. And when we originally set up the crisis billing, we set it up to represent the allocation of those resources, and not necessarily in terms of this future vision for ARPA compliance. So we have all of the codes in place right now, but what we need to do is both for the department's purposes across the other 8 CMHCs and for the CCBHCs, try to create a path in our billing that will make it easier to identify ARPA compliant services. And as part of that, obviously there's the struggle with our prior expectations that for it to be ARPA compliant, it would require a two-person multidisciplinary team that would respond. There are a couple of features about the CCBHC remedy that we came up with that would be different for the 8 CMHCs, but the possibility of it equally applying to the 8 CMHCs still is there. So one of the things that we did is we re-looked at the SPA language, and we looked at some careful wording that we had put in there, one of which discusses a crisis assessment, a mobile crisis screening and assessment within their permitted scope of practice under state law. CMS wants that to be a licensed person, but they defer to whatever the state law is for that. So that's one key piece, is it's a mobile crisis screening and assessment versus there's another provision in the SPA that discusses a real-time clinical assessment in person or via telehealth. And that one does tie to an independently licensed behavioral health professional. So as we dug into this question of licensed versus scope of practice under state law, we noticed a couple of things. When we go into the statute, the licensing does, that part is pretty clear about like a licensed clinician. And then we have a provision in the state law that essentially, it's like one whole paragraph that creates a significant exclusion from the requirement. And it seems like it was written for CMHCs and FQRCs. They're not named in there, but that's FQHC, sorry. They're not named in there, but it appears to be an exclusion for the type of organization that you are in terms of the infrastructure that's there and how the clinical teams end up reporting to someone who is actually licensed or as a prescriber, things like that. So we're like, okay, that's good. There's a potential exclusion there. And it didn't speak specifically to the notion of a crisis assessment. So then we went into the administrative rules, into HEM 426, and we looked at the assessments, the emergency assessments or the crisis assessments. And as you folks know, that's under 42609, under the old emergency services provisions. And in that provision, it ties back to 42608, which is the part that lays out the qualifications for somebody being able to provide psychotherapy. The interesting thing about that is that the emergency services has a person qualified under psychotherapy can provide the crisis assessment. That's how we got to 426.08 and the psychotherapy qualifications. The psychotherapy qualifications include down to the bachelor's level if they're enrolled in a master's program. And there's more additional details. So I met with Evelyn, with Carolyn Lewis. I don't think Julianne was able to join us in that meeting, Evelyn, right? It was you, me, Carolyn, and I believe Carrie as well. Yes. And so we discussed it. I walked them through with this, the statute on there and then through the rules and stuff. And we discussed it and we're all comfortable with that assessment being able to be done by what the rule says for psychotherapy. So as long as that psychotherapy rule is being followed, then that person would be qualified to do a crisis assessment. It's not a full clinical assessment, it's the crisis assessment. So if the two-person team, bachelor's level who's enrolled in a master's, or a master's that's under supervision, things like that, that would be okay. That would qualify for that crisis assessment. So I will pause there for a minute, and because then we'll talk about the clinical assessment piece.
Can you share the statute?
Yeah, we'll have to, I'll pull it up. Jeff, can you pull up RSA 330? I think it's C, RSA 330C. While he's pulling that up, we'll get there. And pop into, if that's the right one, 330C, there's an exclusion paragraph. If it's not 330C, it'll be 330A, I believe. All right. Kelly, did you have a question while we're waiting for that? Okay. So folks, the crisis assessment, when we talked about that, obviously we talked about it being much smaller than a full clinical assessment. Right now, I believe the teams are doing a particular kind of assessment that's named in the contract. I don't know. Evelyn, do you know what that assessment's called? I think it's like the Chicago something.
Are you talking about the Columbia?
Thank you, Columbia. Yeah. Are most of the teams doing that? And is that an abbreviated assessment? You would not consider that a full clinical assessment, correct?
Correct. It's a risk assessment or a crisis assessment.
Right. Okay. Do you folks believe your bachelor's level, that as long as they're enrolled in master's, that that is an appropriate thing for them to be able to do? Who does it now? Is it just the master's level?
Columbia is designed for a whole group of people. So depending, I mean, even police officers can use it if they're trained. But they have different versions. But yes, there are people definitely in that provision that are using it now, at least in Manchester.
So this does not, where we're going with this doesn't concern the leadership here, right? Does it sound reasonable that it doesn't have to be a licensed master? Okay. So that was one of the things that we found would be helpful in this interpretation. The other thing is there is a separate line, a separate paragraph in the ARPA compliance section of the SPA that says that all of the mobile crisis response services must be provided under the supervision of an independently licensed behavioral health professional who must be available to provide real-time clinical assessment in person or via telehealth. Now, what's interesting in this paragraph is it does not say that that licensed behavioral health professional has to be a member of the mobile crisis response team. It means they have to be available. My understanding is I think all of the CMHCs generally have someone of higher qualifications that is available on call, 24 hours a day, not the one person, but you've got that role filled, correct? Yeah, I'm seeing some shaking heads. So, and then because you're a CMHC, all of your clinical teams are under the general supervision of someone licensed anyways, correct? Yes, okay. So we believe that your standard, whoever you have available for those emergency situations would meet that obligation under the state plan. So we thought that between differentiating the crisis assessment and tying that back to the psychotherapy qualifications, that provides more ability for you folks to be able to bill at that ARPA compliant rate. And we also think that the extra coverage of somebody independently licensed is built into your operations already. So that's where we thought that that would be something pretty good news. Now, the third component of this potentially good news is that right now, as you know, we're all billing at the widget level for the individual codes with the modifiers on them for those services. The two psychotherapy codes don't use the modifiers that differentiate the team approach because it's not appropriate to have the psychotherapy, generally not appropriate to have that provided with two people anyways. So if you have situations where you're providing crisis stabilization, maybe you're using a peer for the crisis stabilization and you don't have a second person involved at all. If you have someone that meets that psychotherapy, do a check-in with that person on the same day, and you know that your service is over 90 minutes long, right? So it's at least 91 minutes. So on average, when we looked at the utilization, we're seeing about $300 worth for like an average daily encounter. And then over many days, it can add up. But if you even have that person capable of doing the crisis assessment, check in with the individual on the same day, and the combined time is 91 minutes or more, you could build the per diem at that point for an ARPA compliant because you had two different disciplines. You've provided more than 91 minutes. That gets you to the per diem level, and you had I already said it, you already had the two people, you had the two different disciplines, one capable of a crisis assessment, and you would be able to build the per diem instead. That also means that if the psychotherapy was one of those services, and that would work, you wouldn't build the 90839 or the 90840, you would just build the S9485 at the per diem level, and that would get you that $1,000+ payment. So I know this is a lot. We met internally. We did a lot of research behind it. I'd like to get your feedback, but first, Jeff, did you find the provision in the statute? Okay, let's share the screen so that Kelly can see it and then share whatever question she had about it.
I put it in the chat.
Oh, you put the paragraph in the chat? Okay.
Yeah. And a link to the full RSA.
I don't have a question.
Okay. So that was kind of fortuitous when we saw that there was this exception for psychotherapy. And, basically in an organization like the centers are, because our emergency services points to the psychotherapy. And that's how we landed at this position. Questions?
I have a question, Diana, about the third point of this whole conversation. So are you saying that if two people who meet the qualifications of the disciplines necessary for the ARPA compliant billing provide crisis on the same day, but not at the same time, and it equals over 90 minutes, that qualifies for the ARPA compliant billing?
Yes. That's what we're saying. It wouldn't qualify for ARPA compliant at the individual level, at the individual widget level. So if the peer let me back it up. If the peer provided the service and then it was the next day that the follow-up happened by somebody else, now we can't do if it's less than 90, if it's 90 minutes or less, it won't qualify because those would be individual services. It's by wrapping it into the 24-hour period that you can get those touch points to happen. And simply by making it a 24-hour episode, right, you can get to the ARPA compliant that way. I mean, when we talked to CMS, they recognized that it may not be that the peer and the license level person would be literally providing the same service at the same time. I mean, maybe de-escalation would be appropriate, but they knew it wasn't going to be like a 3-person huddle past that de-escalation moment. So that's how we're like, well, if we can get them more to the per diem level, then it gives a better opportunity. And it does, we talked about the clinical appropriateness of having that second person check in with the individual, even if they're receiving stabilization services in follow-up days. It made sense to do that. Allie?
Do I recall you saying in a prior meeting that one of those services had to be in person and couldn't be telehealth?
Yeah, you still have to make sure that there's at least one in-person responder. Yeah.
Thank you.
Chris?
I heard next day, and then I also heard 24-hour period. So can you just clarify, are we talking literally a day, or are we talking a 24-hour period, 1 p.m. to 12:59 p.m. the next day?
A calendar day. My apologies.
Thank you.
Calendar day. Thank you. Maggie?
I think that did it for me because I was on the same path that Chris was, that I was having them see the peer on Tuesday afternoon and the APRN Wednesday morning, and I was going to be in heaven because it was 24 hours. And yeah, I bundled it together and I got the higher rate. But nope, I see. Okay.
I'm sorry.
I'm sorry.
Yeah, a calendar day. Thank you for clarifying that. So we will be updating the guidance for those things. And the guidance is going to be updated for an additional part of this. The guidance was written to require presumptive eligibility for us to really go up to that 30 days to allow the services to occur because, as you folks know, we started this under our emergency services administrative rule, the 42609, and we did not go initially for a state plan amendment for that, so the rule had to control. The amendment helps address the services from the Medicaid perspective. So it doesn't help address the statutory changes. I mean, the statutory framework that we have. So our emergency services provisions are tied to 135C. 135C does allow the state community mental health system, not allow, it actually requires us to respond to a crisis, right? And then it's per the administrative rules. So the administrative rules has that, I think it's 6 episodes, which we had, in past times considered those like 6 different days of service or 6 units. I think it was 6 units that we had tied it to. But under the guidance, when we did this, we allowed it up to 30 days. With the presumptive eligibility, with the mobile crisis team believing that this person's might be eligible for ongoing community mental health services. We won't need that presumptive eligibility for those individuals that have Medicaid, because when we added it into the Medicaid plan, it is regardless of if they qualify for CMH. So this falls under the regular Medicaid state plan. It's not under the community mental health benefit. So that means you could do SUD, AMI, or SMI. So the billing guidance will have to, we will separately discuss the presumptive eligibility. The presumptive eligibility will still need to be there for individuals that are not Medicaid beneficiaries, because that needs to stick with, we still need to stay within the guardrails of the administrative rules. So I'll pause there to see if that makes sense or if anybody has any questions about it. Okay. Essentially, it gives some administrative relief to the mobile crisis teams if they don't need to worry about presumptive eligibility for CMH level of care for Medicaid beneficiaries. So that should make things a little easier there. Now, the other thing, when the the new guidance comes out, which I want to reconvene the billing team that we used the first time for that. Kelly, remember we had several meetings when we were implementing this in the beginning. So what we'll do is we'll schedule those as soon as we get our first draft ready and talk through those changes. But I'm going to share screen so we can pull up that state plan because this will help. All right, you folks can see that. Let me make it bigger. I have so many screens going. All right. The new billing guidance will be organized into 3 separate sections. One that speaks to crisis response and stabilization services. So this has two sections in it, crisis stabilization and then crisis stabilization centers. Crisis stabilization, the challenge here is that throughout this plan, we mention crisis stabilization, so it can be kind of confusing to follow the logic here, but it's in the mobile crisis response, the ARPA compliant mobile crisis piece. It's referenced in this section, the crisis response and stabilization services, CRS, although it should have been CRSS. I think they typoed that. But here we have crisis stabilization. This can happen in your center. It could happen through a mobile crisis team if it's not ARPA compliant. That is, we would bill at the widget level. Excuse me. It can be done by a peer, right? It can be done in a center. There are excluded facilities, which are like an emergency department or a hospital. So there's just a few excluded facilities, which we already have excluded today. But that could be, it could be a crisis stabilization center. If the community mental health center is calling it like a center unofficially because it doesn't meet all the qualifications of what we have in the plan as an actual crisis stabilization center. The services could still be provided because it's as long as it's considered a non-facility setting. So again, like if Lakes pursues the model for their center that is primarily peer staffed, and it can't meet the qualifications for an actual center here, it would still be able to bill the services that it can provide. And whether you call it a center or not, that's fine, but it would fall under this section of services. And you have triage here, screening, assessment, stabilization, de-escalation, right? Psychology, everything that a mobile crisis team could start doing or an actual crisis stabilization center could do. It's just that the overarching framework for either the mobile crisis team or an actual crisis stabilization center is not met. So it would still be covered again for any SUD, SMI, or AMI for Medicaid. This, again, if we're providing it to a non-Medicaid beneficiary, we'd have to deal with the presumptive eligibility for CMH level of care, okay, because that's part of the 135C framework. Then there's this section for the Crisis Stabilization Center. So the billing guidance will have these all separated because when we talk too broadly, it gets confusing to track. So the Crisis Stabilization Center will have its section there. Again, it includes basically all of the same things. You do have to have the supervision for the biomedical issues as well, potential issues. And your framework here, which we've gone over before, this is very extensive of a staffing composition. Oh, sorry, it just carries over to the next page here. I was like, what? But when we get down to this part, if it's operated, so we would have, it would have to meet these frameworks to be a stabilization center. If it's operated by a CMHC, the FQHC, the Rural Health Clinic, which we don't have to worry about because they're not providers of these services right now, or an acute care hospital licensed by the department, as long as it has the minimum, right here is the big part, at all times of operation, it must have at least the personnel capacity to provide the assessments, crisis interventions, stabilization services, prescribe and administer meds, and to provide basic cardiac life support and first aid. So because you're CMHCs, this is really the main qualifications that you have to make sure you have for all times of operation. If you're opening up for just 8 hours a day at first, that's what you're going to have make sure is available. And as long as you have, access to your overarching framework of, like somebody, a supervising nurse or on-call physician, right? As long as there's someone higher that you can connect to if somebody needs that higher level of service, you're all set. Kelly?
Thank you, Diana. Should we be anticipating any changes in the rates of our crisis services based on whether or not you're claiming them for ARPA versus non-ARPA, or for any other reason?
I think that you should still be able to bill the S9485. If there's more than 2 people involved, that would still qualify for use of the at the rate of the $1,000+ that would still qualify for that. But in this setting, it's not considered a facility. Yeah, I think that would still be ARPA compliant. Well, wait. The backup is that by your mobile crisis team. You're going to have separate staffing, right?
Also, this is not this particular spa. Like one of your spas says it's ARPA and one of your spas isn't, correct?
Yeah, what's ARPA is the mobile crisis because that's the only thing that is care. They
Right,
only provide enhanced match for
correct.
this. That's it. But the billing isn't necessarily tied. The use of the S9485 per diem is not tied to the ARPA enhanced FMAP necessarily. We administratively, Kelly Liberty's group, and Hannah Glines, whatever, they will be identifying what's ARPA compliant for the purposes of the enhanced FMAP. But the codes that we set up weren't tied to ARPA originally. So if you have non-mobile crisis teams that are providing at least 91 minutes of service, and it's 2 persons involved, at least 2 people involved, the different disciplines doesn't matter because it's not being provided by the mobile crisis team. So that different discipline doesn't matter. The rate would be in that $1,000 range, right, already. So by January 1st, there's no way we're going to be able to add anything else in terms of that transition to move forward with sort of like a tiered crisis episode rate. That was something that we wanted to do. We're not going to be able to do that yet. But as long as you have 2 people, it's over 91 minutes, you should be able to still bill the S9485. Does that help?
Yes, I just, we hear different things that we should anticipate rates changing. And so we just need to have enough heads up to be able to do responsible budget forecasting, to be able to, sustain the program.
Absolutely. I do know that we, as you folks probably have already heard, we did submit our agency budget, but it's becoming more and more aware in some of the news story that the state will be, the legislature will be approaching this budget cycle with about a $160 million hole in it. So the department is not hopeful, is not optimistic about the budget being able to carry increases in costs. Chris?
Yeah, you've made a couple of mentions and I'm not following exactly, and that's related to that would be your mobile crisis team versus someone else. I have a mobile crisis team. I don't have anything else. So what would that something else be that would be providing a service? I'm lost there, and my apologies.
So some of the centers that are, if you're standing up a crisis stabilization center, some centers would be pursuing that, resourcing it by their mobile crisis team staff. Others would be using separate staff. So if it's separate staff that you're using for your crisis stabilization center, you could still bill the S9485 per diem rate if you had at least 2 people. Neither one has to necessarily be capable of psychotherapy. But if you had at least 2 people that provided that service and it was at least longer than 91 minutes or longer, then you'd be able to bill at that higher rate. For those centers that use their mobile crisis team, as long as the 2 people were the different disciplines, one capable of psychotherapy, and it was, at a center, meaning in your office or an adjacent space in your office, it's not considered a facility, so that could still be ARPA compliant. That's why we're going to separate out the billing guidance for each particular component of the state plan, because it's too prone to error if we try to put it all together in one space, one conversation. Did that help, Chris?
Yes, thank you.
Okay. All right. Other thoughts, other questions here?
I'm just curious, Diana, on the bottom of the page that we're looking at right now, where it says to prescribe and administer medication. I'm used to the words being prescribe and support self-administration, but am I thinking of this wrong? This is, you want me to give a shot to someone, or I'm being, a little bit dramatic, but that administration of medication is different than what we do, say, in a community residence, or what we do typically with our patients, which is to support self-administration.
I agree with what you're saying. You normally do. Then we can address that in the guidance. Guidance note. We call it med support, right?
Yeah. Support self-administration. At least that's what I'm used to. But I don't run a crisis unit yet, so.
But
And-
no, but it's important
Well,
because we have
so-
medication administration on the developmental services side, which is very different than med support.
And if somebody does take an injectable for their medication and they are off their schedule and that's why they're in crisis, is there the potential that somebody actually would,
Yeah, well,
you know,
for us,
provide
we
the injection?
yeah, for us, we would just bring them into the office and have the nurse go into that office and give it to them. Yeah, but we
Yeah.
wouldn't necessarily do it in the crisis stabilization unit necessarily.
Okay, but you'd
It's
have
a
someone
patient
available too, so that's
Yeah.
good. Yep. So we want to make sure that we clarify that as med support for self-administration, or what did you call it? What's the other word if they're clinically receiving it? I mean, if the nurse is injecting it.
Then it is administer medication, just
Okay.
like you have it.
Okay, I'm just writing a note to myself in the chat there. Anything else? Any other questions or concerns there? That was a good pickup, Maggie. Thank you. All right, I'm going to stop sharing that screen. I can squeeze in one more update. Let me pull it up. The community reentry for the adult program. And I have to specify that I don't believe we had talked here in any significant length about the youth one. I know Carolyn Richards joined us for one session and we talked about it. The adult one is the one that is a little bit more important to give you an update on. These, can you see this this little table here well enough, or do I need to make it bigger?
You could make it bigger, that would be helpful.
All right, let's see what I can do here. Oh, it didn't really make it bigger, huh? That's weird. I will do it this way. Trying to find something open. I'll come back to you guys. Sorry to show you on the screen all yourselves right now. I'll just go there. It has nothing to do with this. I just need to get to a blank page. So I can paste this. This is the old billing guidance. Okay, now I can make this bigger. Better?
Thank you.
Okay. All right. So the department has come up with, remember how we were talking about what would the pre-release contact with the CMHC be? It would be a screening. So I did share that they had gone to the coding specialist consultants the department has. This is the code that the consultant specialist recommended and that DMS approved, Medicaid approved. So the pre-release, this is about a half an hour service for the pre-release screening. We'll have to put some meat on the bones about what that looks like. But it would come in with this new code and this rate. It can be done by, we haven't identified like a particularly licensed level or anything. So we'll go back to you, but I'd love your suggestions on how you would want us to, you know, describe the qualifications of the person that would do this. But my guess is it sounds like it's somewhere between what would the CCBHCs would do for a full first contact. I think it should be a little bit more like a little bit of a get to know you session, at least with the person. But that's what they came up with for the community mental health center. This code is specific and already in our SUD system. These modifiers, the V2 modifier is to identify it through our billing system as part of this demonstration. The chart didn't add it here, but it will be added in actual coding as well. The other appointment, this community-based provider, like a psychiatrist, this is if the individual already had a care provider that they would like to get the service from, rather than getting it from a CMHC or a doorway. So of course the individuals will have choice of what they want to pursue. And if they want to pursue a peer support service, they would go for that. And this is the code. I think I did already report back to you folks that Medicaid landed on that we have to do it at the same rate as the SUD. And that is a couple of dollars shy. This is 2 units, 30 minutes. So it's a little bit more than shy of what you currently use for functional support services. So we'll do, I just got this table like 2 days ago. We're going to add for the demonstration the V2 into the combination. We will also, and we'll do this for the CCBHC demonstration as well, we'll use the modifier HE for if the, well, let me back up. For the CCBHCs, the T1040, well, that's a separate conversation. It's okay, but we're going to use modifiers to indicate the population type. HF for if it's an SUD, primary reason the person is getting the services. HW if it's SMI. And then for these here, if it's SMI, then you would again use your U1 or U2, U1, U2, or U5, I believe, because they shouldn't be coming in as youth necessarily under this model. More to come on that, but I just wanted to let you know that they landed on the services. The expectation is a half an hour or less service in all likelihood from the CMHCs for that pre-release screening. Lisa?
Yeah, did I just hear you say they're using the HF modifier on all of these codes or just specific codes?
Just for the services here for the pre-release. It will not be in the regular fee schedule. We'll issue guidance to give it to you folks, and there will be a community reentry fee schedule that ends up getting published, but it's not going to get added to everything else.
Okay, thank you.
Welcome. Thank you all. I know we're at time. I appreciate all of you. This looks kind of funky in the chat, but I threw it in there.
Hey,
Kelly?
Diana.
Yep.
Go ahead, Kelly.
I just left a note for you in the chat, so it's supported housing, the question from the last time, so that we don't lose track of it the next time we meet.
Thank you. And thank you. We have one that got enrolled. Manchester, your enrollment went through. Thank you very much. And we found out that provider enrollment has a backlog. We did not know about that. We're working to improve communication so that the program areas will know when there's a backlog in enrollment. So if you're struggling with any other enrollment types, let us know, because we have the ability to try to push it up the queue.
Diana, thanks for that. Notice that's great. It's been a long time coming, so appreciate that. I just wanted to ask you, a lot of times we went through a lot, and sometimes I feel like my silence might sound like is a communication that I understood everything you said, or that I don't have any questions, and that's just not true, because I need time to kind of think through this, and I don't know about my team, but I'm just wondering if we have questions, or if we have something that we are confused about. Do you want us to send that in an email? Do you want us to wait till the next meeting? What's the best strategy?
I think you should just send them in an email. Feel free to, you can use the DBH Medicaid billing email address if you want, because the team resources that. So even if I'm straight out in meetings, Lorian and Jeff will, tag me in a little Teams chat, and if they need help with something, they'll ask me for it. Or you can CC that email address and send it to me. I don't mind. I've been trying to answer the questions that have come up from folks. And I've really appreciated getting some of your suggestions and feedback. I know that Patricia, you've sent some, Heather has sent some, Allie has, etc. You all know, you can tell you've known me for a long time. I'm usually more responsive, and my email box is like approaching 4,000 messages right now. So that's why I'm not as timely. I'm very sorry, but please do feel free. I know you folks are desperate to get all of your system configurations handled, staff resources, and know what you can do for revenue expectations. So I know it's a difficult time. I appreciate it.
Okay, great. Thanks for that. We'll do that.
Thanks so much, everybody. Have a good day. Have a good weekend. Be safe out there.
Thank you.